I am Dr. Nancy Dawson. I'm the Director of Genitourinary Oncology at MedStar Georgetown University Hospital. I take care of patients who have genitourinary cancers. So that's men with prostate cancer, bladder cancer, testicular cancer, penile cancer, ureter cancer. So the only cancers I take care of that are both men and women would be kidney, bladder, and ureter. So it's the cancers of the urinary tract. My area of focus is advanced prostate cancer. Not only have we changed how we treat initial metastatic disease, recently there have been new advancements by adding chemotherapy very early in the treatment of new metastatic prostate cancer. The advantage of getting treated at MedStar Georgetown University Hospital is that you are going to be seeing not just a specialist, but a subspecialist. So although I'm a medical oncologist, I'm also a hematologist and an internist, I only see cancers of the genitourinary tract, and I have spent the last 35 years of my life devoted to treating prostate cancer and other cancers in the genitourinary system. So I have a lot of expertise. I've been involved in the development and completion of clinical trials spanning many years that have been involved with the development of basically all of the drugs that are currently approved for the cancers I treat. So you can't really just get that experience and expertise easily, and that makes us a tremendous resource for patients. Genitourinary oncology is the area of cancer that is dedicated to cancers of the genito and urinary tract. So what that means is your urinary tract includes your kidneys, your ureters, your bladder, and the urethra, and your genito tract includes testicles, penis. I don't do women's cancer. That's usually gynecologic oncology. Some people don't realize that those are two different areas. When a prostate cancer is diagnosed, the pathologist looks at the cancer under a microscope and he grades the cancer. So a Gleason score only is in reference to a cancer, a prostate cancer. So the score is anywhere from 1 to 5, where 1 looks almost like normal prostate tissue and 5 is very disorganized. You can't even recognize that it's prostate cancer. So it's graded 1, 2, 3, 4, 5, and that's, they give the first number is the most predominant pathology that they see. So if they look at it under a microscope and 80% of it is grade 4, then the first number is 4. And then if the second most common pattern is a 3, that would give you a 4 plus 3, and your score would be 7. So the reason scores are important is because they're directly related to how aggressive your cancer is and what you can expect. So if you have the lowest Gleason score you usually see would be a 6, be 5 or 6. And those people may never need to be treated for their prostate cancer. Those are patients that sometimes elect surveillance, and we just monitor them periodically following their PSA test, which is the blood test we check for prostate cancer. And those patients may have a long course with a very indolent cancer. A Gleason score of 7 is what we call an intermediate risk Gleason score. And those are the patients that probably most need to make sure they either get radiation or surgery, because that's a cancer that's not slow growing, but not so aggressive that it's already going to be too late. So Gleason scores of 7 are intermediate risk. The high-risk Gleason scores are the 8s, 9s, and 10s, and those patients have a very high risk that even if you do something aggressive to try to cure their cancer, take out their prostate or radiate it, they have a very high chance that their cancer is going to come back. So PSA stands for prostate-specific antigen. It's a protein in your blood, or not my blood, but in a man's blood. Women don't have prostates. So prostate-specific antigen is a protein made by normal prostate as well as by prostate cancer. So a man who does not have prostate cancer will have a PSA level in their blood of somewhere between 0 and 4. And someone who has prostate cancer could also have a low PSA between 0 and 4, but more likely he's going to have an elevated PSA, maybe 5 or 6 or 10. So a part of the screening for prostate cancer involves drawing a blood test, a blood level for the PSA level, and also doing an exam of the prostate gland, done via rectal exam. And what you're looking for is, are there any lumps on the prostate, that might suggest cancer? And then you're looking to see if the PSA level is elevated, which would also suggest possible cancer. PSA or prostate-specific antigen is a protein that is made by the prostate gland. So an enlarged prostate, due to not cancer, benign prostatic hypertrophy, will be associated with an enlarged prostate and a higher PSA than normal. It could be, it could even be as high as 20 or even 30, which would be a high PSA. The other things, if you get an infection in your prostate, so something called prostatitis, that's an infection, that can give you an elevated PSA. When patients go to see a doctor and their PSA is first elevated, often they'll be given an antibiotic to see if it's just an infection and see if it makes the PSA go back down to normal. And you can also actually have, sort of similar to having a heart attack, you can actually have an infarct, a little area of cell death inside your prostate gland that can actually shoot your PSA up to a very high level. So there's other non-cancerous reasons why the PSA can go up. No, it doesn't. It's not uncommon for men to have an elevated PSA between, let's say, 4 and 10, and they get a biopsy and they don't find cancer, because PSA is made by normal prostate. And let's say you have a big prostate. The bigger your prostate, the higher you expect the PSA to be. So if you have a man who has a very large prostate, he might have a PSA of 9 or 10, and it's all non-cancerous enlargement of the prostate, what they call BPH, benign prostatic hypertrophy. In a normal man, most of the male hormone in his body is testosterone, and that's made by the testicles. And only a small amount of androgen, which is male hormone, is made by, for example, the adrenal glands that sit over the kidneys. So in a normal man who has a normal testosterone, if he develops prostate cancer, that prostate cancer is going to be fed or stimulated by male hormones. And so we call that hormone sensitive, because if you remove or lower the male hormones in his body, that cancer will shrink up and die. Castrate-resistant prostate cancer is what I call the weeds. That is cancer that is growing even though you've lowered the testosterone levels to what we call castrate. So the goal of treating advanced prostate cancer effectively, initially, when it's hormone sensitive, is to get the testosterone levels down to a very, very low level that we refer to as castrate. And that will work for a while in controlling a man's cancer. So it may be a year, it may be 2 years, it could be longer, but eventually, even though the testosterone level is very low, or as we call it, castrate, the cancer will start to grow. It's at that time that we start what we call second-line therapies for prostate cancer. Prostate cancer starts to make its own androgen, and that androgen stimulates the cancer to grow. So the secondary therapies that we give are drugs that lower or block those androgens. So there's a drug called abiraterone, and there's another drug called enzalutamide. Abiraterone actually blocks the making of all the androgens in the body, and enzalutamide actually blocks the ability of androgen to stimulate the prostate cancer. So those are what we call second-line hormonal therapies. And patients, and those drugs have clearly made men live significantly longer. We have other options as well. We have immune therapy. There's something called Sapulocil T, goes also by the name of Provenge, and that's an immune therapy that actually allows the patient's own immune system to attack their prostate cancer. We also have several kinds of chemotherapy that have been associated with making men live longer. There's a drug called docetaxel, there's one called cabazitaxel. The most recent therapy to be approved for advanced prostate cancer is something known as radium-223, which goes by the trade name of Xofigo. And that is actually a radiopharmaceutical. It's something that gets injected into your blood, and it actually goes to the bone where the cancer likes to go, and it goes wherever cells are actively dividing, which is the cancer. And it gives it a little tiny mini dose of radiation and kills it at all the different sites in the bone. And that therapy is also approved and has also been shown to make men with advanced prostate cancer live longer. There's several tests that when I see someone, I do what we call a staging evaluation. So usually that involves a bone scan to look to see if the cancer is in the bone, a CT scan, abdomen and pelvis to see if it's in any lymph nodes or organs, a chest x-ray, and then if they're on hormonal therapy, we're certainly going to be checking a testosterone level to make sure it's low, like we want it to be. We'll be checking the PSA level and some basic chemistries to make sure, you know, the liver and kidney function is good. And then I usually do a bone density scan on patients. So a bone density scan is just a radiographic test. It's just plain x-rays to look at basically the thickness of your bones. Now the reason we do that is one of the negative side effects of hormonal therapy is it can cause your bones to get thinner. So every year a man is on hormonal therapy, he loses 1 or 2% of the density of his bones. And that can put him at risk for breaking bones or having other complications because his bones have gotten thin. So if you check for the bone density and you see that the bones are getting thin, then you can initiate treatments that can reverse that. If you get diagnosed with prostate cancer and it's early stage, and let's say you've got a low Gleason score, you might not need to be treated at all. You could be followed by what we call active surveillance, which means we check your PSA level every 3 months, and we actually biopsy the prostate gland every 1 to 2 years. So it's not a passive surveillance, it's an active surveillance. There are patients who don't need to be treated for their prostate cancer. If you have more advanced disease, if it's already spread, then removing your prostate or radiating your prostate is not probably going to help you. So people with advanced disease do not have their prostate removed. It's the patients who are the intermediate risk patients that I mentioned. Those patients definitely need either, assuming they're otherwise healthy, they would need either their prostate to be removed or to have it radiated. You can have side effects from radiation. You can have side effects from surgery. They're very different side effects. Radiation does not cause urinary incontinence, but surgery can. Surgery doesn't cause the irritable bladder symptoms, but radiation can. So the symptoms are different. If you actually look at what one of the things that is talked about a lot, which is erectile dysfunction, an inability to have normal sexual function, that's actually probably very similar between radiation and surgery. Immunotherapy, at least in the world of oncology, is referring to therapies that depend upon the patient's own immune system to attack their cancer. So in the case of prostate cancer, the one that's currently approved is Sipuleucel T. And in that therapy, men actually have blood cells removed from their body, what we call antigen-presenting cells. So they actually have blood cells removed from their body, and then those cells are exposed to something called prostatic acid phosphatase. It's something that prostate cancer makes. And they actually sort of incubate those cells with this prostatic acid phosphatase and something that's an immune booster, and it gets their own cells to start being triggered to be able to fight any cell it will encounter that actually makes prostatic acid phosphatase. So they take their cells and they sort of rev them up, and they turn them into what is called Sipuleucel T, which is sort of activated cells, activated lymphocytes, and they give them back they reinfuse them back into the patient. And those cells go around looking for any prostate cancer cells, which it identifies by cells that make prostatic acid phosphatase. And wherever it can see those cells, it can attack them. And it can also actually recruit other cells that are already in the patient's body to sort of join the force and sort of start a little army against the prostate cancer. There are some new drugs that are being developed that are immunotherapy drugs for bladder and kidney cancer. They are broadly referred to as anti-PD-L1 and anti-PD-1 drugs. So PD-1, it's a bad term, but it stands for Program Death 1. And these are agents that actually depend upon the fact that certain cancers make PD-L1 and PD-1. So how it's sort of been explained in sort of a simplified way is that the PD-L1 on the tumor is sort of hiding the tumor from the patient's immune system. So what happens is you have the patient's own lymphocytes aren't able to see the cancer. That's how it's sort of simplistically explained. So if you go and you give them a drug that attacks or blocks PD-L1, it allows that cancer to suddenly be seen by the patient's immune system, and their own immune system, their own lymphocytes can go and attack that cancer. We have several therapies that we can use that are currently approved. Some of these are pills, some of them are injections, but they depend upon the fact that kidney cancer is stimulated by growth factors that the cancer itself is making. And if you can block those growth factors, you can actually cause the cancer to shrink and become sort of semi-dormant. When I'm taking your history, or if you're already my patient, I know whether you would be an appropriate candidate for a trial. So I'm not going to offer you a trial that you're not appropriate for. I'm only going to talk to you about a trial that you seem suitable for. And you're not going to sign up that day. We're going to talk about it. I'm going to provide you information about it. And then if you're interested in a clinical trial, then we would actually have you consent to the trial, and then we would screen you to see whether you can go on the study. When I'm following a patient and I have them on a treatment, I am doing a couple of things. One, I'm talking to them. So when a patient comes in to see me, probably the most important thing I do is I ask them how they're doing. And are they having any side effects? And are they having some symptoms that are concerning to them? Like, are they losing weight? That's usually not a good sign. Or are they having new areas of pain? So if someone is being treated, you're going to ask them how they're doing. That's going to tell you probably as much as any test. And then you're going to order appropriate tests to see if their cancer is looking better or their cancer is looking worse. We have a group called GUMDROP, which stands for Genitourinary Multidisciplinary Regional Oncology Project. And who we are urologists, oncologists, radiation oncologists, people who are doing clinical trials in prostate cancer, bladder cancer, kidney cancer, testicular cancer, and we have a website. So if you go to gumdroptrials.org, you can actually identify yourself, or your family member can identify yourself as having bladder cancer, prostate cancer, kidney cancer, and then you can just answer a couple of simple yes/no questions. Has your cancer spread? Are you on hormonal therapy? Have you already had chemotherapy? So you can answer a couple of questions, and it will list any clinical trials that you might be eligible for. You can click on the name of the hospital, and it will tell you who the coordinator is for that clinical trial, their email, and their telephone number. Basically, all of the cancer centers and major urologic oncology groups that are focused on clinical trials have their trials posted on our website, and we regularly refer patients to each other. We, as it seems amazing to some people, have chosen to work together, to collaborate, to try to make sure our patients have access to clinical trials. Even if it's not a trial I'm doing myself, I'm going to want my patient to know about a trial and let them choose which trial they want to be on.